Hi everyone, welcome back to our medical ethics class. Today we'll talk about the issues of human research, clinical trials, and also the issue of assisted suicide. So firstly, we'll talk about one of the most emotionally and philosophically important topics in bioethics. So the morality of euthanasia and physician-assisted suicide. So this subject touches the very core of human dignity, suffering, autonomy, and what it means to live, or to choose to die with meaning and moral clarity. So advances in medicine now force us to revisit age-old questions in new and often unsettling ways. One of the central dilemmas in this topic is this: when is it morally acceptable or even obligatory to let someone die? And when, if ever, is it morally permissible to kill someone for their own sake? So we'll examine the moral distinctions between different types of euthanasia, discuss famous legal cases, if there is time, and also analyze how ethical theories like utilitarianism, Kantian ethics, and natural law approach these dilemmas. So let's start with definitions. So what is euthanasia? So euthanasia means good death. And in medical ethics, it refers to the intentional ending of one's life for their own benefit to relieve suffering. So we typically distinguish: there is active euthanasia directly causing someone's death, such as by lethal injection. Also passive euthanasia, so that is allowing someone to die by withholding or withdrawing treatment, like turning off a ventilator. There's also another distinction to be made here. So there is voluntary. So voluntary means with the informed consent of the patient, and there is also non-voluntary euthanasia. So that means when the patient is not competent and hasn't expressed a choice. For instance, they're in persistent vegetative state and they've not left any documents or any notes of how they want to be treated in such situations. There is also involuntary, so that is against the patient's will. So this is widely condemned and illegal. Euthanasia is legal and widely practiced under strict guidelines. Active euthanasia, however, it remains illegal. Physician-assisted suicide, which involves a doctor providing the means for a patient to end their own life, is legal only in a few states like Oregon and California, and only under very specific conditions. So I guess we don't have enough time, so we'll not talk about the exact cases and also specific moral theories relevant to this, but you are welcome to read into the textbook further and also talk about these issues in your discussion posts. By grounding his argument in widely accepted ethical values in contemporary medical ethics, and then examines objections, both ethical and policy-based, and systematically refutes them. So Brock begins with the central ethical argument. He argues that the very same two fundamental ethical values supporting the consensus on patients' rights to decide about life-sustaining treatment also support the ethical permissibility of euthanasia, including death, based on their own values. Brock notes that dying is increasingly a prolonged medicalized process, and many people care deeply about how and when they die. So the variability in what individuals consider an acceptable quality of life makes it especially important that individuals retain control over the timing and manner of their death. The second fundamental ethical value is individual well-being. So it means that life is not always a benefit. When a competent patient judges their life is no longer worth living, it becomes a burden to them, it even becomes a torture sometimes. So this is the same judgment patients make when refusing further life-tending treatment. So crucially, both values are conditional and competence. Brock emphasizes that euthanasia should not be permitted in cases of dementia or untreated depression. Brock raises our attention towards this very crucial distinction when it comes to this issue of debate, which is the killing versus letting die distinction. So one of the Brock's most important local arguments tackles a key philosophical issue. So that is the issue of this distinction. So how do we distinguish between killing and letting die? So opponents often claim that euthanasia is morally worse than foregoing treatment because it involves actively killing the patient. But Brock argues that stopping treatment, for instance, removing respirator, can also cause death, just as directly as a lethal injection. He uses thought experiments to show us this. So, for instance, he imagines, so if a physician extubates a patient at the patient's request, the patient dies, that seems morally acceptable. But if the son of that patient removes the respirator, we'd call it killing, even if the act was physically the same. Therefore, the difference lies not in the act itself, but in intent, consent, and motive. He concludes that some killings, such as those in euthanasia with consent and good motives, can be morally justified. Having established his argument about the previous distinction, Brock now talks about whether euthanasia violates the right not to be killed. So we think people have a right to life, people have a right not to be killed. So that's one of the reasons why we think killing is wrong, and we have different laws and moral philosophy that's against killing. But Brock argues here that wrongful killing is wrong because it deprives someone of a valued future. But if a person competently decides that they no longer value continued life, they can waive this right. Thus, voluntary euthanasia is not a violation of rights, but a case of competently waiving a right. So this is a key philosophical move here in his paper. Rights are not absolute. They can be waived under conditions of informed voluntary consent. Brock also addresses different policy questions that is, or such as, even if euthanasia is sometimes morally permissible, should we permit it as a public policy? So should we pass it in terms of social or legal concerns? Brock argues for his point by talking about potential good and bad consequences of legalizing euthanasia. So basically, we do a pros and cons table and judge. So he argues that the potential good consequences are respecting autonomy. People who now suffer without access to euthanasia would be empowered to end their lives on their own terms. Also, reassurance. So even people who never use the option may feel reassured knowing they could access it. So they wouldn't think their pain would be forever. They can end it when they want it to end. Also, mercy. Some patients experience severe suffering that only euthanasia can relieve. Also, humanity. A quick and dignified death may be better than prolonged and dignified decline. There are also potential bad consequences as well. So, firstly, it undermines trust in doctors. Physicians might be seen as killers rather than healers. Brock argues this worry is overstated and can be avoided with clear consent-based policies. People might also worry about erosion of palliative care, that euthanasia might replace investment in better end-of-life care. But Brock noticed that similar concerns were raised about the right to refuse treatment, but were not borne out. Also, the slippery slope argument. So it argues that legalizing voluntary euthanasia might lead to non-voluntary cases. So this has been a very major debate for the past few years. Brock acknowledges this is a serious concern, but argues that proper safeguards can manage the risks. To make his point more solid and more convincing, and to really establish the grounds for his paper, Brock here tries to address the slippery slope argument. So that is Brock's most extended and nuanced discussion of objections in this paper. So Brock firstly defines two types of slippery slope concerns. So concern one, abuse. So people might be pressured into euthanasia or misdiagnosed because of abuse. And two, expansion. Euthanasia might be extended to non-voluntary cases. So Brock's responses are here. So firstly, Brock offers concrete things that we can offer concrete procedural safeguards to confirm competence and voluntariness. 3, require psychiatric evaluation. 4, require a waiting period, and also ensure the patient is fully informed. So Brock supports the idea of limited social experimentation, trying euthanasia in a few states with careful regulation and monitoring. So interestingly, Brock admits that one form of the slippery slope might be real. So in some cases, the logic of self-determination and relief of suffering may justify non-voluntary euthanasia for incompetent patients. However, he argues this risk does not justify denying euthanasia to competent patients who request it voluntarily. So he thinks that at least we can have this legalized for competent patients. Brock closes by emphasizing that the debate turns not only on abstract principles, but also on empirical facts and practical safeguards. So the kind of practical suggestions he gives are also very important here. So Brock's overall philosophical strategy was first to start from widely shared values like autonomy and well-being, then extend those values to euthanasia through consistent reasoning. He then addresses conceptual objections such as killing versus letting die and rights. He then considered policy consequences, both good and bad consequences, and then he tries to acknowledge the risks, but then argue that they can be managed and try to find different solutions or kind of reframing these bad consequences. So that was the main structure and strategy of his paper. Then move on to Rachel's paper, so James Rachel's classic essay on euthanasia. And this was one of the most widely cited essays in medical ethics. So Rachel's in this paper challenges a central tenet of mainstream medical ethics, the idea that there is a morally significant difference between active and passive euthanasia. So Rachel's central thesis is pretty bold and proactive. So he argues that there is no morally relevant distinction between actively killing a patient and passively allowing them to die. So of course, as you can see, he is against euthanasia. So he argues that in fact, in some cases, active euthanasia may be morally preferable, but passively allowing them to die basically is actively killing them. So this claim cuts against the grain of legal and medical policy, especially the American Medical Association's position at the time, which allowed for passive euthanasia, such as withholding or withdrawing treatment, but prohibited active euthanasia, such as administering a lethal substance. So I'll firstly talk a little bit about the structure of the argument. So Rachel builds his case through a pretty clear 4-part structure. So firstly, it's an introductory critique of the AMA doctrine, and then it's a comparison of active and passive euthanasia in terms of suffering. Then part 3 is a critique of decisions based on morally relevant factors, and 4 is a famous thought experiment involving 2 cases, Smith and Jones. So let's talk about each part in turn. Let me talk about the first part. So Rachel opens by citing the AMA's official 1973 statement, which, so direct quote from it, the intentional termination of the life of one human being by another mercy killing is contrary to that for which the medical profession stands. However, the AMA allows the cessation of extraordinary means of life support if the patient or family agrees. So this forms the core of what Rachel's calls the conventional doctrine. Active euthanasia, that is directly causing death, is always impermissible, and also passive euthanasia, that is withholding treatment and allowing death, is sometimes permissible. So Rachel challenges this doctrine by pointing out the tension. So if the motivation for passive euthanasia is to reduce suffering, then in some cases, active euthanasia may achieve that goal more effectively, so why forbid it? Then the second part of the paper talks about euthanasia and the reduction of suffering. So to highlight this inconsistency from the first part, Rachel's presents a compelling example. So he argues that imagine a terminal cancer patient in unbearable pain who will die in days even with treatment. The patient asks to die, and the doctor agrees to stop treatment. But here's the key insight. Withholding treatment might allow the patient to suffer for longer. A quick lethal injection would minimize that suffering. Therefore, Rachel argues active euthanasia may be the more humane choice. So to say otherwise is to endorse the option that leads to more suffering rather than less. So this argument appeals to a humanitarian impulse, the idea that medical decisions should aim to reduce suffering. Rachel uses this to undermine the assumption that passive euthanasia is always preferable comparing to other forms of euthanasia. Then next, Rachel turns to an example involving newborns with Down syndrome and other correctable defects like intestinal blockage. He observes that some doctors and patients choose not to operate on infants with Down syndrome if they also have a defect requiring surgery. But if the infant doesn't have such a defect, the same child may be allowed to live. So the absurdity here is this. So the decision about whether the child lives or dies depends not on whether the child has Down syndrome, but on whether there is an operable defect. Rachel calls this a morally irrelevant criterion. The conventional doctrines allows this irrationality because it only permits letting die, not killing. So people wait for a medical excuse, like an obstruction, rather than making a direct decision. So Rachel's conclusion is that the conventional view enables morally perverse outcomes. Part 4, Rachel talks about 2 case studies with Smith and Jones. Rachel makes this point in the 4th part. Rachel argues that if we morally condemn both equally, and most people do, then the distinction between killing and letting die is not in itself morally significant. So, he made such a point. Rachel is pretty aware that there will be a lot of objections. So Rachel also tried to kind of go against and push back those objections. So Rachel knows that people might object to his paper by saying that people claim passive euthanasia is morally better because the doctor does nothing. But then Rachel argues that letting someone die is a self-immoral action, so it's a decision with consequences, subject to evaluation. So Rachel makes 2 key clarifications. First, that inaction can be morally significant, like not giving meds to a treatable patient. And 2, legal distinctions don't justify moral ones. Just because active euthanasia is illegal doesn't mean it's immoral. So the conclusion is that if the doctor's decision was the right one, the method used is not in itself important. So the overall strategy of Rachel's paper I listed it here, so I'm not going to it more directly or in more details. Rachel here is not necessarily advocating for more killing, rather he wants us to rethink whether the means of euthanasia should matter more than the motive and outcomes. So he's calling us to rethink what we value and where we put our attention when we try to make a decision. Then we move on to a pretty remarkable legal document filed in the US Supreme Court in 1997, the Philosopher's Brief, authored by 6 of the most influential moral and political philosophers of the 20th century. So Durkheim, Nagel, Nozick, Ross, Scallon, and Thompson. So the brief was submitted in support of patients seeking physician-assisted suicide in two cases. So, Washington versus Glucksberg and Washington v. Glucksberg and Vaco v. Quill. So while the philosophers held diverse views on moral and political issues, they united on this to argue a constitutional point that if someone is terminally ill but competent, they should have a constitutionally protected liberty interest in choosing the time and manner of their death. So their argument draws not only from ethical reasoning but also from the American constitutional tradition, particularly the due process clause of the 14th Amendment and prior landmark decisions such as Planned Parenthood. So let's walk through the structure of their argument, keep moral and legal claims, and reflect on what it means for liberty, dignity, and end-of-life autonomy. Brief central point is this. So the Constitution protects the right of mentally competent, terminally ill patients to make deeply personal decisions about the timing and manner of their death, and to seek assistance from doctors in doing so, provided appropriate procedural safeguards are met. This is not a claim about the morality of suicide or euthanasia per se, not a proposal for unregulated physician-assisted death. It is a legal and constitutional argument grounded in a right to liberty, dignity, and personal autonomy. The authors emphasize that this liberty interest does not compel doctors to assist, nor does it require states to remain entirely passive. Rather, states may impose safeguards, but they may not impose blanket prohibitions that erase this liberty entirely. So I'll quickly talk about the structure of the paper. So if this brief follows a logical structure, so firstly it tries to frame the legal question. So the cases do not ask the court to determine the morality of suicide, but to recognize that competent individuals have a constitutional liberty interest in making such decisions themselves. And part 2 talks about the liberty interest is constitutionally protected. It's grounded in Casey, abortion rights, and Cruzen, refusal of treatment. Liberty includes intimate and personal choices central to personal dignity and autonomy. And part 3, moral parity between letting die and assisting death. So they argue that there is no morally relevant difference between letting a patient die, as in withdrawing life support, and actively helping them die, like through medication when the patient consents and is competent. And also part 4 talks about state interests can justify regulation, but not absolute prohibition. So they argue that states may safeguard against mistakes, coercion, or instability, but blanket bans are disproportionate and deny a basic liberty. And the conclusion they made was that the Constitution forbids states from imposing one view of life's meaning on all citizens, especially at the end of life. So for the first part, the brief cites Planned Parenthood v. Casey. At the heart of liberty is the right to define one's own concept of existence, the meaning of the universe, and of the mystery of human life. This right to define existence includes how one dies, particularly when death is imminent and suffering is extreme. Cruzen supports this too. If a patient can refuse life-sustaining treatment, that must be based on more than bodily integrity. It is about control over life and death. And the second part So it talks about how the state justifies bans on assisted suicide by claiming that helping someone die is active killing, while letting someone die, such as removing a ventilator, is just allowing nature to take its course. So the brief counters that this moral distinction collapses in the context of end-of-life care, where both acts share the same intent and effect, honoring honoring a patient's decision to die. And if we permit removing life support when requested, we should also permit the patient to ingest a lethal medication when requested, assuming competence safeguards. The third part talks about the religious and ethical neutrality under the Constitution. A core claim is ethical pluralism. The government must not impose one religious or ethical view, such as that life must be preserved at all costs on all citizens. They argue that people differ and we should recognize that. Some will resist death to the very end. Others see continued existence, intubated or unconscious, as a form of degradation. The state cannot constitutionally decide for them. As the brief states, just as it would be intolerable for government to dictate that doctors must always prolong life, it is also intolerable for government to dictate that doctors may never help someone to die who believes further life means only degradation. And part 4 argues that state interests cannot justify blanket prohibitions, so states may have legitimate interests, like protecting people from coercion, like irrational decisions or severe depression, which could induce requests for death. But those risks do not justify denying everyone this liberty. Other medical decisions carry similar risks, like refusing chemotherapy or creating advanced directives. We don't ban those, we regulate them. So they think that it should be the same for other. It should be the same for this issue as well. This philosopher's brief also tries to respond to this slippery slope concern. So Brock's also tried to deal with this concern as well. So critics may fear that the slippery slope, legalizing assisted suicide for some, may expand to non-terminal cases or coerced euthanasia. So the brief acknowledge that risks, but insists that this is a regulatory challenge, not a justification for prohibition. They cite model statutes and real-world protocols, such as in Oregon, the built-in protections like multiple physician views, waiting periods, and mental health evaluations. They also offer an analogy here. They argue that the state cannot ban free speech simply because it might incite violence in some cases. Similarly, it cannot ban all physician-assisted dying because some cases might go wrong. So that was the main structure and the main content of the philosopher's brief. Okay, so then let's move on to the issue of the ethics of human subjects research and clinical trials. So for this part, I don't want to go into each paper directly. I want to more sketch the landscape for you all about this issue. So this is also one of the most ethically charged and challenged areas in medicine research involving human subjects. So this includes everything from clinical drug trials to psychological studies, and it raises urgent moral questions about consent, exploitation risks, and justice. And it's pretty relevant as well. So if some of you study medicine or do research, frequently you have to do all sorts of forms, and you're required to have approval from ethics committees. So I think this also highlights some kind of fundamental contradictory values here for human research. So at the heart of human research, we might have two values: the pursuit of knowledge and the commitment to beneficence. So that is acting for the good of others. So when humans have the research subjects, these two values can come into deep tension. They can clash a lot. The aim to know and the aim to heal don't always align, and that misalignment has at times led to some of the most disturbing moral failures in moral history. So let's start with talking about the history. So there have been a lot of past abuses. So the modern ethics of human subjects research was basically forged in response to horrific abuses. So like World War II, Nazi doctors performed a lot of terrible experiments on prisoners. And these led to the Nuremberg Code in 1947, a set of principles establishing the necessity of voluntary informed consent and prohibiting experiments likely to cause harm. So sadly, the abuses didn't stop there. So in the Tuskegee syphilis study begun in 1932, black men with syphilis were misled into believing they were being treated when they were, in fact, being studied without their consent. So even after penicillin became the standard treatment, it was withheld so researchers could observe the natural course of the disease. Many died and others infected their partners as children. So in the 1950s, researchers at Willowbrook State Hospital deliberately infected developmentally disabled children with hepatitis to study the disease progression and test vaccines. Parents were often coerced into giving consent by being told their child wouldn't be admitted to the overcrowded hospital unless they agreed. These and other cases led to the development of additional ethical frameworks, like the Declaration of Helsinki, the Belmont Report, and International CMO guidelines. These documents establish principles that continue to shape medical research today. So that was basically the historical context here. All of these also are pretty relevant to clinical trials and how it's done. So most modern research takes place through clinical trials, which are scientific studies that test interventions on human beings. The goal is to determine if a new drug or procedure is safe and effective. So a lot of you might have medical background, but for those of you who do not know as much about clinical trials, so I want to talk about this a little bit. So what are clinical trials like? So to ensure trustworthy results, trials use so first control groups, where one group gets the treatment and the other gets a placebo or a standard therapy. And two, blinding. So subjects are and researchers don't know who gets which treatment, so it prevents biases. Also randomization. So subjects are assigned by chance, not choice, which ensures the groups are comparable. These methods make clinical trials the gold standard for medical evidence, but they also raise very difficult ethical questions. I'll then go into some specific ethical issues that have come up regarding human research and clinical trials. So I think the first is the problem of control groups. So the central ethical debate focuses on these two questions. For instance, is it ethical to give a patient a placebo when an effective treatment exists? So is it unfair to those patients? And most guidelines say no, unless there is no proven therapy or the condition is minor. However, a lot of people think this is indeed and deeply morally problematic. The other is clinical equipoise. So there is genuine uncertainty in the medical community about which treatment is better. So if equipoise exists, randomizing patients into control and experimental groups can be ethical, especially with informed consent. There is also this part of physician belief. So if the physician believes one treatment is better, some argue it is wrong to let a random process decide a patient's care. So a lot of people think that you would just randomly draw from a pool of patients' names and just give people treatments that you know is worth. A lot of people think this is very problematic, but this shouldn't happen in a hospital. So there is that. And there is also the dilemma of placeables. So because we have a lot of placebo controlled trials, so sometimes in the non-controlled group, people were given placeables. So this is the most reliable way to isolate a treatment's effect, but it poses serious risks when treatments are denied effective treatment, especially for serious illnesses like AIDS, cancer, or depression. Sometimes giving placebos to patients might lead them to miss the kind of critical windows when when their diseases might actually be cured to the most extent, or sometimes, and for instance, for a extremely depressed patient, if you give them placeables, maybe they miss that window of curing their depression when it hasn't developed too much worse. That might lead to their suicide. That might lead to them having to take antidepressants for their whole life. So a lot of people think this is, again, very deeply morally problematic and unfair to the patients who get the placeables. So I want to talk quickly about the AZT trials in developing countries. So researchers have withheld non-effective AIDS treatments from poor pregnant women to test cheaper alternative. This is viewed as an ethical exploitation by some, but also practically justified by others if standard treatment was available locally. So it's deeply pretty complex and a lot of contested ideas or thoughts and a lot of debates going on. There is also this issue of informed consent. So sometimes what we have in mind is ideal, but the reality is much different, and it operates in a much, much more complex way comparing to our ideal worlds. So informed consent, of course, is pretty foundational, right? I think we all know this term and we all think about this, right? But foundational idea as it is still pretty debated. So sometimes subjects may not fully grasp complex medical information. Sometimes they just do not have the resources or capacities or knowledge to actually know what they're asked of. There is also this problem of voluntariness. Sometimes it's hard to define whether someone is actually voluntary. Sometimes they may be driven by desperation, hope, or poverty may compromise true voluntariness. So sometimes we don't have a way to actually track whether a patient is voluntary. There is also the problem of financial incentives. So this can lead to undue inducement, though some argue payments are just compensation. And I think the problem of human research and clinical trials are so, I guess, incentivized, or the extent of it actually increases, or the sensitivity of it increases when it comes to vulnerable populations, because they are more prone to being harmed or destroyed by such unfairness. So it poses special challenges when it comes to ethical questions or scenarios regarding vulnerable populations. So the first is children. They cannot legally consent, and parents or guardians must do so. But children's consent is also required in many cases. I think it's always a moral dilemma when it comes to children. So some argue that they should have autonomy, some argue that parents or guardians have to choose for them. I think you can see this kind of issues being addressed in a lot of medical shows. Also for those who are mentally impaired, well, they may need surrogate consent. So research allowed if risks are minimal or potential benefits are significant. However, for those who are severely mentally impaired, again, kind of like scenarios of children, we have a lot of debates regarding their autonomy, their moral status, and whether they should have the freedom to choose for themselves, and whether we are sort of discriminating against them if we didn't allow them agency and just assume that they don't have agency and autonomy, and they shouldn't be given freedom to choose for themselves. I think there is also the group of global poor, they often lack access to care, so this raises issues of justice. So should they receive the same standard of care as in rich countries? Should benefits of research be shared? So I think this interacts with a lot of political issues and social issues and probably international relations issues. So for instance, in the Haiti AIDS study, poor patients recruited in research were given less care than in the US. This raised concerns about exploitation and moral double standards. And ethical theories, of course, interact a lot with human research and the ethics of it as well. So, for instance, utilitarianism might support research if it maximizes benefit. It would justify clinical trials if long term gains outweigh harms, while Kantian ethics might reject using people as mere means. They think informed consent is essential. Vulnerable individuals must never be deceived or coerced. While Russian justice, we've all heard of Rawls. Well, he might stress protecting the worst off. So they might argue that research must benefit the poor and vulnerable, not just exploit them for others' gain. They might ask that we should share research results, make those public to all countries in the world, especially those who are poor. So I think there are lots of debates in this area, and it's very hard to find an answer to it. And I think as technology develops, as kind of global politics becomes more complex, those issues become even more complex. So I think that's all we have for today. And of course, I probably raised more questions than given answers to you. And I think a lot of things in this class are very worth discussing. So I'm looking forward to hearing from you all in the discussion space. And thank you so much for today, and see you in the next week's lecture.